Colposcopy of the cervix including upper/adjacent vagina. The physician examines the cervix, including the upper/adjacent portion of the vagina through a colposcope, a binocular microscope used for direct visualization of the vagina, ectocervix, and endocervix. The physician may insert a speculum into the vagina to fully expose the cervix as part of this procedure. Colposcopy of the cervix including upper/adjacent vagina, with biopsy, S, of the cervix and endocervical curettage. With biopsy, S, of the cervix. With endocervical curettage. The physician views the cervix, including the upper/adjacent portion of the vagina through a colposcope, a binocular microscope used for direct visualization of the vagina, ectocervix, and endocervix. The physician may insert a speculum into the vagina to fully expose the cervix as part of this procedure. For biopsy, an instrument is inserted in the vagina and used to take one or more small tissue samples of the cervix. For endocervical curettage, a small curette is passed into the endocervical canal, which is the passage between the external cervical os and the uterine cavity. A specimen is obtained by scraping in the canal with the curette. The instrument is removed. Colposcopy of the cervix including upper/adjacent vagina, with loop electrode biopsy, S, of the cervix. The physician inserts a speculum into the vagina to fully expose the cervix. A biopsy specimen of cervical tissue is removed by the loop electrode excision procedure, LEEP. LEEP uses a hot cautery wire containing an electrical cutting current as a cutting instrument. Due to the electrical current, a grounding pad is attached to the patient's leg during the procedure. Colposcopy of the cervix including upper/adjacent vagina, with loop electrode conization of the cervix. The physician performs a loop electrode excision procedure, LEEP. The physician inserts a speculum into the vagina to fully expose the cervix. The electric grounding pad is placed on the patient's leg and safety checks are run. The cutting current is set. Using a loop, the lesion is removed as one specimen. If the lesion is large and another pass is required, 2 equal specimens are removed and labeled for the axis of orientation. The same procedure is done again with a smaller loop if an endocervical excision is necessary. The bleeding vessels are cauterized, the vagina is inspected for any accidental injury, and the instruments are removed. Colposcopy of the entire vagina, with cervix if present. With biopsy, S, of vagina/cervix. Paravaginal defect repair, including repair of cystocele, if performed, laparoscopic approach. The physician performs a colposcopy of the vagina and the cervix, if present. The patient is placed in the lithotomy position and a speculum is inserted into the vagina. The vagina is inspected through the colposcope, a binocular microscope providing direct, magnified visualization of the vagina and cervix. The physician examines the tissue for discharge, inflammation, ulceration, and lesions. The cervix is exposed, cleansed, and inspected for any ulceration or lesions. Acetic acid may be applied to help enhance visualization of the columnar villi and any lesions. Laparoscopy, surgical, colpopexy, suspension of vaginal apex. The physician performs a laparoscopic colpopexy and suspends or reattaches the apex of the vagina to the uterosacral ligaments to correct a uterovaginal prolapse and restore the vaginal apex to its normal anatomic position, often post-hysterectomy. Through small stab incisions in the abdomen, a fiber optic laparoscope and trocars are inserted into the abdominal/pelvic space. The bowel is mobilized or moved aside to provide a better view and easier access to the uterosacral ligaments. A vaginal probe is placed for manipulation and to help ensure the cul-de-sac is properly closed. The peritoneum is incised over the vaginal apex. After the vaginal vault is elevated into its normal position, and the cul-de-sac is obliterated, if necessary, a suture is placed through the base of the right uterosacral ligament and through the apex of the vagina, securing it posteriorly to the top of the rectovaginal fascia and anteriorly to the pubocervical fascia, to a dermal or mesh graft, if placed, and secured. Colposcopy of the vulva. With biopsy, S. The physician performs a colposcopy of the vulva, the external genitalia region of the female that includes the labia, clitoris, mons pubis, vaginal vestibule, bulb, and glands, and the vaginal orifice. The patient is placed in the lithotomy position and the vulva is inspected through the colposcope, a binocular microscope used for direct visualization of the vagina and cervix. The bright light of the colposcope is directed so as to inspect the vulva and perianal area for any lesions or ulceration. In 56,821, a biopsy is taken of any vulvar tissue in question under direct vision. The number and size of the biopsy will depend on the lesions. Pressure is applied and hemostasis of the biopsy site is achieved.